to Speak Our Minds, the fight for youth mental health, the podcast that delves into the inspiring journey of youth mental health advocates who took a stand and transformed a system. Together with your host, Heidi Baskfield, we'll explore the landmark lawsuit that held the state of Colorado accountable for failing to provide essential youth mental health services and won. In each episode, we'll unpack the intricate details of the lawsuit, guiding you through the legal battles and the monumental settlement that set the foundation for a working system of mental health. We'll examine the steps Colorado is now taking to build a comprehensive and effective mental health care system for its youth, highlighting both the challenges and the triumphs along the way. Join us as we learn from experts in other states who have successfully navigated similar crises, offering invaluable insights and strategies. Hear firsthand accounts from parents, providers, and professionals who are deeply committed to ending Colorado's youth mental health crisis. Their stories and perspectives will shed light on the impact of the lawsuit and the hopeful path forward. Whether you're a concerned parent, a mental health professional, or an advocate for change, this podcast is your guide to understanding the profound transformation taking place in Colorado's youth mental health landscape. Welcome to Speak Our Minds, the fight for youth mental health. Let's embark on this journey together.
Well, with me today is Dr. David Keller. And Dr. Keller is not only heading up the efforts here in Colorado with our local AAP chapter, but is a leader within the Children's Hospital Colorado and University of Colorado at Anschutz in the pediatric community. He's going to talk to us more about his work going on today, but is also here with us because of his experience with the Rosie D lawsuit, which is really the mother of all EPSDT lawsuits that has led to the work that is now informing what's happening here in Colorado. So today, we're going to talk about Rosie D. We're going to talk about those lessons learned and how we should be thinking about the engagement of the primary care community here in Colorado as we navigate our own lawsuit. So welcome, Dr. Keller.
Hi, thanks for having me. This is really exciting to talk all about this.
Well, we're thrilled to have you. You want to tell everybody what you do now?
Sure. Well, I do a number of things, but I think one of my favorites is that I get to co-chair the Legislative Policy Committee for the Colorado chapter of the AAP. The pediatricians of Colorado are incredible advocates for children, and it's just fun to see them take on an issue and run with it. And we have a number of members who are really interested in improving the quality and kinds of behavioral health care treatment available for their patients here in Colorado. So I've been working with them on that. And we can talk about how this is connected to the Rosie D case, but I helped Sandy Fritsch, who's a child psychiatrist here, set up a program called COPCAP, the Colorado Pediatric Psychiatry Consultation and Access Program, which supports primary care docs around the state who are trying to take care of kids with behavioral health problems, and then do a lot of work with our state Medicaid agency as we try to move towards value-based care and trying to help them understand what value means for children, which is kind of fundamentally different from adults. As I always say, the goal of healthcare for children is to maximize their potential. The goal for healthcare for old people like me is to cushion the fall as we gradually fade off the scene. And those are different things. And our state Medicaid agency has been very open, HCPF has been very open to discussing how to set things up differently. So that's been a lot of fun too.
Well, thank you for sharing that. Let's jump into the discussion about Rosie D. So Rosie D was a class action that advocates filed against then Governor Romney for failing to appropriately provide services under the EPSDT requirement within Medicaid. And really, the outcome of that lawsuit has led to several subsequent similar legal actions, including the one here in Colorado. Can you share why you know all about Rosie D and what your engagement was at the time?
Sure. Well, if you'd like to read about it, Google Rosie D and Me blog, and you will find it's still posted. I just pulled it up to make sure. The blog that I wrote for the 2 years during the initial implementation, where I was working with health law advocates, a law firm, a public interest law firm in Boston, on the implementation. Back then, I was a pediatrician in the town of Webster, Massachusetts, working for the University of Massachusetts School of Medicine, running a primary care practice, and just could not get behavioral health services for any of my kids. The nearest place they could go was 20 miles away. They actually had to take a road that dipped through Connecticut. So I always used to joke they had to go through 2 states to get to behavioral health care, which was a little bit crazy. And we had a child psychiatrist there, I think 2 half days a week, who I developed a good personal relationship with so that I could work with my kids. But we really couldn't take care of the kids that we were needing to. And this was recognized. I think it was the Center for Public Representation and 2 other public interest law firms brought the case on behalf of a group of 9 children who had serious emotional disturbance and had not received early and periodic screening, diagnostic, and treatment services as required by law. And so they went to court over it, and the court found that the state was not in compliance with the EPSDT standard within Medicaid, and that they had to get brought up to snuff. So unlike the case here, the case actually went to trial there. So they had an actual court settlement. The judge then said, you have 2 years to come up with a remedy for this. I think the case was decided in 2005 or maybe 2006, and they had to have the remedy in place by July 1st, 2007. That date I remember.
When Dr. Keller is referring to the differences between the 2 lawsuits, what he's talking about is the fact that in Massachusetts, the case took 6 years to finally reach its ultimate conclusion, where the court did side with the plaintiffs in finding that the state of Massachusetts had failed to properly implement its EPSDT requirements. Here in Colorado, we were fortunate enough. The state agreed only after 3 years of litigation that had similarly not met its obligation with EPSDT. But instead of waiting for a court order, the state of Colorado chose to sign a contract, essentially, with plaintiffs' counsel, saying that it would, in fact, take direct action to ensure for successful implementation of EPSDT now going forward.
And that's actually when I formally got involved with the case. I got asked to be an expert witness on the screening portion of the plan. So I provided testimony to the court on what a screening program should look like. And on the 1st of July, 2007, we started implementing. And back then it was a big change. We were in a very different place with mental health. Screening was new. Nobody was doing it. And so we had to really start from nothing to get the screening part of the program up to snuff. Everybody was worried that when we started screening, we'd have no place to send the kids, and which was probably true. And so they also, as part of the plan, they had to set up a series of contracts around the state. I think there were 32 of them for different regions for what to do when you had somebody who screened positive. And then they would implement, use the CANS assessment, I think something that we're doing here, that's CANS, to determine which services the child was eligible for. And in particular, were they eligible for the kind of home-based services that were being required by the court. The court monitor who was appointed was brilliant. She kept everything running on track. Every 6 months, she had to report to the judge on what was going on and how well they were doing. And the program was actually fully implemented by 2009. And it was just a tremendous change. I'll give 2 examples from my practice, if you'd like, or we could stop.
No, please do. I would love the examples. Keep going.
Yeah. So one example was a child I had come into my office for a well child visit. And in the course of the screening, we discovered that he was having some of the kind of red flag symptoms. A 4-year-old child who was injuring kittens. I mean, he was injuring pets, and actually had actually killed one. And the family didn't tell me that until the very end, but I was able to call a mobile unit. I said, no, this needs immediate assessment. This is really scary. And I was able to call a mobile unit who came to my office and did the assessment, which just would not have happened before, and determined that he had a serious emotional disturbance. And then services kicked in, and it turned out to be complicated. And it was a complicated social situation and all sorts of other things. But I could just with a single phone call, I could call and suddenly this team just descended, which was just wild and great. And I think the other case that I remember was one of my patients had ended up in a mental health hospital, had ended up hospitalized and was coming out of hospitalization on a whole bunch of medications that I didn't understand and was told to find a psychiatrist and didn't. And again, calling that center, they were able to coordinate the care so that the landing was a lot smoother than it would have been. And those things both happened. I wrote about them in the blog. If you want to read 250 blog posts, you probably find it in there. But those are the kinds of things that we were able to do once the system went into effect.
I think, Dr. Keller, what's so remarkable, both about your examples and the situation on the ground with respect to Rosie D, was the level of comprehensive system reform that occurred that has since motivated others to follow suit. Can you talk about why you feel like a lawsuit may have been so critical in generating that level of change, and why other states may be looking at this kind of approach to really drive a difference?
Well, yeah. I mean, it's always helpful to have somebody watching. And in this case, I think it was remarkable. The case remained open until 2021. So from 2006 to 2021, there was a court-appointed monitor monitoring what the state of Massachusetts did with children's mental health. That, to me, is extraordinary. I mean, I left in 2013, so I had lost track of them then. But the fact that that particular court made such a long-term commitment to change was just impressive. I think that the other piece of it was that everyone knew the system was broken, and we kind of lucked out. You mentioned that the lawsuit was initially against Governor Romney, and in 2006, Governor Romney left the State House, and we got a new governor in. Oh, I'm showing my age. I should remember his name, and I can't. But he actually made children's mental health one of his key issues. So instead of contesting the lawsuit, which I think if Romney had stayed in office, it would have been taken and appealed, the new governor decided, nope, we're going to do this thing. So we not only had the court watching, but we had a governor who was behind us in making these changes. So I think that those two things really worked in our favor. And then, of course, within Massachusetts, they had a very, very well-organized coalition, actually started out of the Children's Hospital there in Boston, that we had 5 major partners, including a parent organization that were the sort of lead organizations. And then there were upwards of 130 other organizations around the state that were part of that coalition. And that coalition showed up and drove change. I mean, my contribution to it, my blog, blogs were new back then. And I showed up to the meeting and realized that these meetings were happening in places that had Wi-Fi access. And if I sat there with a laptop, I could live blog what was going on. This was before Twitter. So I guess I was a pre-tweeter. And what that did is expand the scope of everybody who knew what was going on. And in particular, I discovered that the staffers at the committee in the state legislature that were focused on what legislative reforms are going to be needed to comply with the court order read my blog religiously. When I finally met them 2 years later, they said, "Oh, you're that guy." And I was like, yeah, okay. But I think we were able to pull together really unique groups of people to make a difference there. And that's the kind of thing we need to do in Colorado right now as we're working through this settlement.
Yeah, say more about that and the value proposition of consistent engagement and broad engagement of stakeholders. I mean, similar to you, I mean, I'm just essentially being a copycat, Dr. Keller, but instead of using live blogs, we're using the podcast as the tool to keep people informed of what's happening and keep people engaged. Can you say from your own experience, why is that important?
Sure, critically important. I think that because, especially then, but even now, because all of these systems need to be adapted to the place that they're in. And Massachusetts is not Colorado. It's a very different place. Massachusetts rural is very different from the Eastern Plains. And certainly Massachusetts mountains are very different from our mountains. They're nice little mountains, but, they're small. And so it's a different place. And so I don't expect you can just take the model of what was built there and have it work here. And if we don't have broad stakeholder engagement from all of the communities of Colorado, then we're not going to be able to revamp the system. We're also working in a different time. Back then, we didn't have electronic health records, for example. Now we do. So that should make some of this easier and some of it more challenging in both ways. Back then, screening was new. I just was looking at my first blog, was saying, hey, we instituted screening at my practice yesterday, and it wasn't so bad. I mean, everybody thought the screening thing was going to be a complete disaster. So just letting people know that it's okay to do screenings, that parents aren't going to be offended, that kids aren't going to feel labeled, that all of those things that folks worry about aren't going to happen was really, really important. And then the whole process was really complicated. I mean, they were building these new contracts. Some of them resulted in new agencies forming in new areas. These were all new things. And again, I think of the rollout that's going on within the Behavioral Health Administration right now is really complicated. Who actually knows what a BASO is? And we don't know how a BASO is going to work because we've never had one before. And so there's an opportunity then when it's new to shape it in such a way that it really does work for children. So you can't shape it if you're not there for the conversation.
Dr. Keller is referencing the Colorado Behavioral Health Administration, which was created in 2022 to be able to oversee and coordinate the administration of mental and behavioral health services in the state of Colorado. Why that's relevant here is that state Medicaid, through healthcare policy and finance, is solely responsible for the implementation of the settlement agreement. And yet, there is a role for the BHA to be played here, but that role remains unclear. And so how will HCPF, Colorado State Medicaid, and the Colorado Behavioral Health Administration coordinate, join forces to ensure for effective settlement? Well, at this point, that's anyone's guess.
No, that's exactly right. And I think, the next part of it is, I think we have some very committed individuals within the department that really want to see the effort, the compliance work well, that they would like to see very positive system reform come from this. But can you say more about, if it's just an effort led within the department, why we might fall short, like why we might not get there if we don't have this live beyond very smart, well-intentioned people at HCPF? Why does it need to live more broadly?
Well, and the folks at HCPF that I talk to tell me this all the time. They need to know what's going on in the world. And it's great when you have a policy or you set up a payment system, but until you know how it plays out in the world writ large, you don't know if it's going to work or not. And does it work for families? Does it work for children? Is not a question that can be answered. I used to say from within the walls of HCPF, but of course, most of them work from home nowadays. But, from in the virtual world, you need to have the connection to the boots on the ground as you're building things new, or you run the risk of building things that don't work and you don't know that they don't work. So I think that's the value. The value is in the feedback loop that comes from having that kind of sort of large stakeholder engagement.
Yeah. I want to talk about the specific role of primary care in all of this. Mm-hmm. And if you could say, you provide some really great examples as to why you got involved and the difference it made for you as a pediatrician when you were practicing in Massachusetts. Let's now bring this equation to Colorado. And as we're moving into the creation of this implementation plan and then its subsequent rollout, what is it that you really want Colorado to do in its implementation plan when it comes to thinking about including and designing a system that's working to support the primary care element of this?
So a lot of the work, particularly in this lawsuit or in the cases that were brought, were the tip of an iceberg. It was kids with serious emotional disturbance or a subset of kids with behavioral health problems writ large. It's really kind of a pyramid. And part of your goal, I think the overall goal of the system shouldn't just be to treat the kids at the top of the pyramid, but to try to keep people from climbing up that mountain or being forced up that mountain. That if we can get to them earlier, and there's pretty good data on this, if we can get to them earlier, then we can keep them from needing the kinds of services that those kids with serious emotional disturbance need. So that's why I'm glad we're thinking about that. And I think the one of the differences between the cases here and the cases there is they made that explicit in the Rosie D case, that this is about the whole system, not just the SED kids. And so the risk is that if you focus too much on the kids in the top, you end up engaging in a kind of a game of whack-a-mole where you take care of this kid who has this really acute problem, and then they get better, and then the next one pops up. And at some point, you have to look upstream. At some point, you have to look further down that pyramid. That's where primary care comes in. And maybe we need to think about all the ways in which we can reach kids who have not risen to the top of that pyramid, but the system I work in, primary care system, does that really well. If you have families that have relationships with a primary care provider, and that's the hardest thing in today's environment. I'll just speak for myself. I mean, I'm now mostly administrative in my role. I'm in clinic one day a week. So I have a panel of about 400 patients. I try to keep in touch with them, but I'm actually not in the clinic most days. And so I do it electronically. I do it with phone calls. It's not as good as when in Massachusetts, I was in clinic 4 days a week. And so if you wanted me, pretty much you could find me almost any day. There was one day I wasn't there. So I think that's a challenge for families to have those kinds of relationships. But it's that relationship that you can get within a primary care practice that you can build on to be able to get the child the services that they need earlier so that they don't progress to becoming the kid with SED who is in the emergency room at our children's hospital waiting for placement because there's no place left for them to go. And that really needs to be our goal, is to how do we set up a system so that we can keep kids from needing to get to that point.
Studies show that prevention and early treatment programs for things like depression and anxiety can cut the risk of developing severe mental health conditions by 50%, at least according to the World Health Organization. And what's interesting here is that primary care settings are poised to effectively deal with things like child depression and anxiety. So it would make sense that we create the ability for the system to serve these kinds of conditions within a pediatrician or family doctor's office. The other thing that's interesting is that according to NAMI, the National Alliance on Mental Illness, when a mental health issue goes untreated in childhood, the likelihood of needing higher levels of care, such as inpatient services, increases by 75% as the individual enters adolescence. It's clear that engaging the primary care community and ensuring that they can effectively address these conditions is critical to the success of these kids.
In your opinion, what do you think pediatricians and family docs need to be effective in that space? Like when you look at our current landscape and you're very plugged in to all the different ways in which pediatricians and family medicine providers are interacting with Medicaid, what are some of the barriers that we're going to have to address pretty quickly that allow these providers to be and do the kind of thing that you're talking about here?
Well, so I'm really lucky now. I practice in a practice that has what's called integrated primary care. And some people call it advanced primary care. But it's a model where I'm still there. I'm the pediatrician, but I have available to me a child psychologist who literally lives next door. I can walk over and tap her on the shoulder and say, hey, can you come over and talk with this family? Or they need to have some short-term therapy, or we need to work with them on how to regulate their kids' behavior or that kind of stuff. And they'll come over and do it. So the more we can promote integrated practice, I think the better we're going to be able to keeping people from moving up the food chain. I mentioned the COPCAP program earlier. Most practices don't need to have a child psychiatrist on hand most of the time. I'll say I'm spoiled. I actually do have one on hand sometimes, but I don't think that's necessary. What is necessary is knowing where you can call a child psychiatrist and talk to them and have them coach you through some of these cases, because sometimes we just get in a little over our head. I actually called our COPCAP program 2 weeks ago about a kid with ADHD who I was trying to manage, and I tried 3 different medications and wasn't having much success. And I needed the idea for the next medication. And I could have referred them to a psychiatrist, and It would have taken 6 months to get an appointment, and then they'd get in and they would have gotten it. Or I could call CopCap and say, yeah, try this one. Oh, okay. That's what I thought, but I just wanted to check with somebody before I did it. So I think those kind of supports for our primary care docs are important. And then we supplement that with a pretty vigorous ECHO program where we have continuing education for docs so they can learn how to deal with these folks. Those are two things that we've done in the state that I think can be expanded to the point where they would provide adequate support. And then the other one that I'm coming to like more than I did at first is the iMatter program, where we have the availability of telepsychology. Now, I got gray hair. I'm old, so I'm a little skeptical of tele, but it seems to work pretty well for some of my patients. And I'm glad to see that the legislature decided to make it a permanent program. I hope we're able to continue funding it going forward, because that's going to be an issue. And ultimately, that's going to be the issue for a lot of these things. When we talk about Rosie D back in Massachusetts, it was expensive. And I think some of the costs, and there was tremendous benefit when the recession of 2008, 2009 hit, to having the judge watch over the programs, because when the state was cutting budgets, they couldn't cut that budget, because that would have been 2 years into the program. And if they'd taken massive budget cuts, it would have damaged it severely. And so we didn't have those massive budget cuts through that time. And I think that enabled us to grow at a time when kids really did need that kind of support. And that's always the fundamental problem in this state is how do we allocate the resources? How do we make sure that the money is available to be able to implement the program that we need?
Yeah, well, and that I think brings up my next point, which that's always going to be an issue in all states, right? Is how we ensure that the appropriate level of resources are being driven in to support an effective system. If you were to say, here's the one thing I'm the most excited about and feeling really optimistic about with this lawsuit, what is that? And then what is the one thing that you're like, woo, we got to make sure we are addressing this early on, sort of the biggest obstacle that you're seeing? Talk about those two things for me.
Well, the thing I'm most optimistic about, Heidi, is that you're amazing and your leadership role in this has been extraordinary. And so I have tremendous faith in your ability to lead us through the morass that we are entering into with this. The thing that I worry the most about, because Rosie D was a very successful EPSDT lawsuit, Massachusetts actually had another one that wasn't so successful around dental care. Same issue, couldn't get dentists to take it, and they had a 5-year remediation plan. And Medicaid did a bunch of things to try to enhance the accessibility for dentists, and it really didn't work. And the case ended. The judge found that the state had acted in good faith and had not solved the problem, essentially because the problem was not solvable in some ways, and so ended the oversight. And that was a disappointment. And so that's my fear, is that we will try a bunch of things. We might not get it right at first, and that we won't keep trying, because this is a long game and we need to keep working on it for a long time. My friends at HICPUP, I know, are ready to do this. They care about the kids. That is absolutely clear whenever you talk to any of the folks who are trying to implement this, that they care about the kids and they're trying to make it all work. But I worry that we will try and not get far enough. And I guess that's my biggest worry.
Yeah. Well, while I appreciate, obviously, the compliment, certainly the success of this effort will depend on you and others continuing to stay at the table and helping provide the guidance in this process. One of the things that occurs to me, and I agree with you, that there has to be this commitment to the long game, and that there are going to be any number of pitfalls that we encounter along the way that we have to move our way through. And that includes a new governor in the not too distant future. So Governor Polis is only going to be serving in this capacity for a little while longer. And I think maybe to close out, Dr. Keller, how do we make sure that as we're approaching this next gubernatorial election cycle, that the successful implementation of this lawsuit is part of the discussion of people picking our next governor? What do we need to do there? If you were to talk to your fellow Coloradans and say, this is what's important, what would you tell them? How do we create this expectation such that a new governor doesn't mean we lose momentum?
That's where we need parents. I'm sorry. I mean, I'm a physician. You've been working in sort of government affairs around these policy issues for decades. And we will do a lot of the sort of behind the scenes work, but we need the parents in front. If parents are voters, if parents demand it, it will happen. And when I talk to parents, they know that their kids need mental health services, and they know that they are really hard to access. And if you haven't tried to access them for your child, you know a friend who's been trying to access them, or your grandkid who's been trying to access them. And I think we just need to make everyone understand this is a community problem that we need to solve on a community level. And much as I love Colorado's rugged individualism, but this is one we have to do together, and we need voters to hold the folks who are running for office accountable. Well, how are you going to deal with this problem? It's still a crisis. When Children's called the mental health crisis back in, what was that, 2020, 2021? Somewhere back there.
That's right. Yep.
I mean, everyone was sort of surprised. Why are you calling that? We're in the middle of COVID. This was a bigger crisis before COVID, and we knew that COVID was going to make it worse, and it did. And it's perhaps easing off a little bit right now. It's not quite as acute as it was. That doesn't mean it's gone. And we need parents to remind everyone that, nope, it's still out there, and our kids are in trouble, and we need to take care of them.
I mean, amen to all that. And what I also hear through that message is we need to stay at the table. We need to keep talking about our experiences. And it's not just the gubernatorial election and our governor that we should be having these conversations with, but it should extend to our state legislators, county leaders, city leaders, all of those that have the ability to sort of pull those different policy levers. It takes all of us working collectively is what I hear you saying.
Yep. Seem likely to get a new state rep next time around, and I've already met with him and talked to him about this stuff. So we will continue. We all have to do that and just keep it going. And then I think it's up to those of us who've been working in this space to really help guide the state in what's going to work and what do we think we can actually implement that will work so that we can make all of this happen.
Well, Dr. Keller, I can't thank you enough for being here today, for your consistent leadership and engagement and guidance. And we'll look forward to having you back as we move through this process and talk more about what is the experience that pediatricians in particular are having. What do they want people to know? And what's the feedback they want to give? So we'll look forward to talking more.
Absolutely. Always a pleasure to talk with you, Heidi, and thanks for having me on.
Thank you for joining us on this episode of Speak Our Minds, the fight for youth mental health. We hope you found today's discussion insightful and inspiring. The journey to transform Colorado's youth mental health system is far from over, and your engagement and support are crucial in sustaining this momentum. If you have any questions, comments, or stories you'd like to share, we'd love to hear from you. Connect with us on social media or visit our website at www.speakourminds.org for more resources and information on how you can get involved. Don't forget to subscribe to the podcast on your favorite platform so you never miss an episode. Together, we can make a difference and ensure that every young person in Colorado has access to the mental health care they need and deserve. Until next time, stay informed, stay engaged, and keep advocating for a brighter future. The Fight for Youth Mental Health with your host, Heidi Baskfield. Thank you for listening.